The moment those ICU doors swing open, you stop being a patient and become a number on a monitor. Every breath you take, every heartbeat, every drop of fluid going in or out of your body is being tracked by machines and a nurse who is legally not allowed to look after more than one other person. What you don't see is the controlled chaos. Most people think the ICU is just a fancier hospital room. It's not. The ICU operates by a different set of rules, a different staffing model, and a different definition of what counts as an emergency. Here's what hospitals don't tell you about the 7 things that happen the moment you cross that threshold. And number 4 is the one that haunts families the most. If you're learning what really happens behind hospital walls, hit subscribe. We're exposing the codes, the protocols, and the secrets that healthcare workers live by every single shift. Let's start with the first thing that happens, and it happens before you're even off the gurney. You get assigned an acuity score. Every ICU patient is graded on a scale that determines how sick you actually are compared to everyone else on that unit. We're talking ventilator dependence, vasopressor drips, neurological status, organ failure points. The higher your acuity, the more resources you consume, and the more the charge nurse has to reshuffle the entire floor to keep you alive. Here's something most people don't know. Your acuity score doesn't just decide your care, it decides which nurse you get. The most experienced ICU nurses are reserved for the highest acuity patients. Here's the terrifying part. If you're wheeled in at 2 a.m. on a weekend and your acuity is sky high, there is a real chance the only nurse qualified to manage you is already managing someone else who is just as sick. This is the nightmare scenario every ICU charge nurse fears, and it happens more often than anyone is willing to admit publicly. The second thing that happens the moment you're wheeled into the ICU is that you're connected to more monitoring equipment than you've ever seen in your life. Cardiac monitor tracking heart rate and rhythm. Arterial line measuring blood pressure beat by beat. Central line for medications and blood draws. Pulse oximeter for oxygen levels. Foley catheter measuring every drop of urine output. Possibly a ventilator breathing for you. These aren't optional. They're mandatory for ICU-level care. Here's what this means. You have zero privacy. Your body functions are displayed on screens visible to everyone walking past your room. Nurses, doctors, respiratory therapists, specialists. They're all watching your numbers in real time. Every vital sign is being recorded continuously. If your heart rate spikes, alarms sound. If your oxygen drops, the entire team knows within seconds. You're under surveillance every moment you're in that ICU bed. The third thing that happens is sedation gets adjusted immediately, and you might not wake up for days. If you're on a ventilator, you're likely being sedated to keep you comfortable and prevent you from fighting the breathing tube. The level of sedation is carefully controlled, deep enough that you're not in distress, light enough that you can be woken for neurological checks. But here's what families don't understand. Their loved one might look peaceful, but they're in a medically induced coma. Here's the truth ICU staff know. Families often beg doctors to wake them up, not understanding that the sedation is necessary. If you're critically ill on a ventilator, being awake and aware would be terrifying and dangerous. You'd panic, fight the breathing tube, try to pull out lines, and cause more harm. The sedation isn't cruelty, it's mercy. But watching someone you love unconscious for days while machines keep them alive is traumatic for families in ways hospitals don't adequately prepare them for. The fourth thing that happens, and this is the one that haunts families the most, is that visiting hours become restricted or eliminated entirely, and you're separated from your loved ones exactly when you need them most. ICUs have strict visiting policies. Some allow family only during certain hours. Some limit visitors to 2 at a time. Some ban children completely. During COVID, many ICUs banned all visitors, and patients died alone connected to machines while families watched on iPads. Here's why this destroys families. Their loved one is critically ill, possibly dying, and they're being told they can't stay, can't be there, have to leave. They're standing in hallways crying, begging to be let back in. Meanwhile, the patient, if conscious at all, is confused, frightened, and surrounded by strangers. The separation compounds trauma on both sides. ICU staff know this, and many hate enforcing visitor restrictions. But the policies exist because too many visitors disrupt care, spread infections, and interfere with life-saving interventions. The fifth thing that happens the moment you're in the ICU is that your medical team multiplies exponentially. You're no longer being managed by one doctor. You now have an intensivist, a critical care specialist overseeing your ICU care. You have your primary team. You have consulting specialists for every organ system failing, nephrology for kidneys, cardiology for heart, pulmonology for lungs, neurology for brain. Each specialist is writing orders, recommending treatments, and sometimes contradicting each other. Here's what creates chaos. You might have 6 different doctors with 6 different opinions about your care. The intensivist is trying to coordinate everyone, but specialists see their organ system in isolation. The cardiologist wants medications that the nephrologist thinks will harm your kidneys. The neurologist wants tests the intensivist thinks are too risky to transport you for. Your family is getting conflicting information from different doctors. Nobody seems to be in charge, but actually everyone is in charge of their piece, and the intensivist is trying to integrate it all into a coherent plan. The sixth thing that happens is that your body begins deteriorating from being in the ICU itself, even as the ICU is keeping you alive. This is called ICU-acquired weakness. You're lying in bed, sedated, not moving. Your muscles start breaking down within days. Patients lose 1 to 2% of muscle mass per day of bed rest. After 2 weeks in the ICU, you might have lost 30% of your muscle mass. You'll need physical therapy to relearn how to walk, sometimes how to swallow. Here's what's also happening. ICU delirium. The combination of sedation, sleep deprivation from constant noise and interruptions, isolation from family, medications, and critical illness itself causes confusion, hallucinations, and cognitive impairment. Patients have terrifying hallucinations, thinking staff are trying to hurt them, believing they're being held captive, experiencing vivid nightmares they can't distinguish from reality. This ICU delirium can persist after discharge and contributes to PTSD in ICU survivors. The seventh thing that happens in the ICU is that end-of-life conversations start happening much sooner than families expect. The ICU team is watching your trajectory. If you're not improving, if organs are failing despite maximum support, if interventions aren't working, palliative care gets consulted. Families are asked about code status. Do you want CPR if the heart stops? Do you want to be on life support indefinitely? What would the patient want? Here's what breaks families. They weren't prepared for these decisions. Their loved one was admitted yesterday, and today doctors are asking about withdrawing life support. It feels too fast, too soon, too final. But ICU teams know the statistics. They know when interventions are futile. They know that prolonging ICU care past a certain point isn't extending life. It's prolonging dying. These conversations are necessary, but the timing feels brutal to families who aren't ready to let go. Beyond these 7 things, here's what else is happening in the ICU that nobody warns you about. The cost is astronomical. ICU care costs $3,000 to $10,000 per day. A week in the ICU can generate bills exceeding $100,000. Insurance covers most of it, but not all, and families are left with devastating medical debt from their loved one's ICU stay. Here's what's also true. Survival doesn't mean recovery. Many patients survive the ICU but are never the same. Post-intensive care syndrome affects up to 50% of ICU survivors. Persistent physical weakness, cognitive impairment, depression, anxiety, PTSD. The machines kept them alive, but the ICU experience damaged them in ways that take months or years to heal, if they heal at all. If you're still watching and learning what really happens in ICUs, make sure you're subscribed. We're breaking down medical realities that most people never see until they're living them. What happens the moment you're wheeled into the ICU is a complete transformation of your medical care. You're assigned an acuity score determining your resources. You're connected to continuous monitoring. You're possibly sedated into unconsciousness. You're separated from family. You're managed by multiple specialists. Your body begins deteriorating from ICU-acquired complications, and end-of-life conversations begin happening sooner than anyone expected. The ICU is where the sickest patients go to either recover or die, and the line between those outcomes is determined by acuity scores, resource availability, specialist coordination, and the brutal efficiency of machines keeping bodies alive while medical teams fight to bring patients back from the edge. Understanding what happens in the ICU doesn't make it less terrifying, but it explains the controlled chaos, the restricted visiting, the multiple doctors, the sedation, the monitoring, and the difficult conversations. All of it designed to maximize the chance that you walk out of those ICU doors alive, even if you'll never be quite the same person who was wheeled in.